Thank you very much, Bob. It's a wonderful talk that you gave. It's going to be very hard to argue against all the science that you have just shared with us. Also, you, similar to Bob, you have my email there and our website, and everybody is welcome to communicate and collaborate with us when you so desire. The point I was asked to argue was not if there is no need to do molecular or any type of staging. It was rather that in salvage therapy is the same for everybody. These are my disclosures. And my second disclosures talk more about the source of where I'm coming from. I cannot, in all honesty, say or ever argue that there should be one treatment for everybody in the relapse setting. Particularly after in my graduation, I got part of the Maimonides oath for the physician, or after following the recommendations where Sir Iliam Osler, in that we treat patients rather than we treat diseases. In the Tate Museum, you can see how everything that goes around when you get exposed to a patient. So not every patient is the same, and it's not all about the patient, it's also about the family and the repercussions that when somebody is ill. In the Rijksmuseum, you can also see that in the 1600s, there was the need to have special attention to each patient in different way. In our myeloma patients, for instance, they cannot lay down and they cannot do the full decubitus because they have such severe back pain that they have to sleep sometimes sitting, and this picture also depicts that. So each patient is differently. So we have to, I cannot argue that we have to use the same treatment for everybody, but the treatment has to be personalized. Now, in this era, there are several parameters that we have to pay attention when we are treating patients. It is the line of therapy that they are, if there is a plateau phase, how long was this quiescent state, how aggressive or what's the kind of relapse that the patient has, or if it has high-risk disease. So talking about the line of therapy, you know that the further you go through the natural history of the disease, the shorter is going to be the survival and the duration of the response. This is very clearly documented in several trials and observations, and this is the one from the Mayo Clinic. Also, we have evidence from the same group that the longer the plateau phase is, the longer is going to be your survival post-transplant. So that's another parameter that you have to take in account when you're going to approach the patient with relapse multiple myeloma. Now, how aggressive is the relapse depends on how the patient started. If the patient presented in such a way with explosive disease, with hypercalcemia or renal insufficiency, the relapse may present in the same fashion in 80% of the cases, but they may have different presentations in other 20% of the patients with extramedullary disease, non-secretory relapse, or light chain only. In fact, when you're talking about the features of the relapse, you can find relapse with both serum heavy chains and light chains in 35% of the patients, whereas you can have light chain escape in 10% of the cases. And those patients, as observed by the group of Dr. Morgan, the patients who have this type of light chain escape do worse than the patients who relapse with their initial presentation. Now, in the hospital right now, I was just coming out of service. I have this patient who's a 56-year-old gentleman with a long-standing history of multiple myeloma, more than 5 years, and he has these large masses in the axilla, in the chest, eroding into the chest wall, and has a high LDH, as you can see. He has been admitted for a third transplant. This we're trying to debulk him and then offer him some other type of therapy once the hematopoiesis can be recapitulated and gains counts to participate in clinical trials. Next, in the next room, we have this patient who presented with diplopia and base of the skull tumors. And as we were starting steroids and radiation therapy to the base of the skull, the LFTs starting to get abnormal, and he has these liver abnormalities, which in biopsy proven to be plasmablastic myeloma. Clearly, those patients who have progression with extramedullary components do much worse, and as you can see of the bottom curve. And when the patient relapse, and when relapse after double induction or two agents, what we call the double refractory or now triple refractory, the outcomes are very poor. So the situation in the relapse refractory patients is not as easy that discernible that we can actually target one patient over the other. It requires a more global approach. I want you to pay attention to the curve of the right. Look at the overall survival of those patients who are double refractory, and the event-free survival or progression-free survival of only 5 months. So that's the barrier that we have to break when we're treating patients with relapse and refractory disease. Now, we cannot target one single abnormality. Dr. Richardson also mentioned that patients with myeloma have over 5,000 mutations in a given time, and this is a map of frequency on patients on newly diagnosed. And you can see as patients progress in the relapse setting, there is even more alterations. So it's even more difficult to try to target single abnormalities molecularly to try to make a dent on molecularly on the patients. And this happens not only at the diagnosis, but multiple clones or subclones reappear as the patients progress. So there is still a large amount of genomic instability that does not allow targetable agents. So talking about precision medicine in myeloma, we have to consider every patient with a relapse refractory disease at higher risk. Defining higher risk just appears to be of more relevance in the first line. As I said, genomic instability precludes the rational action of a molecular treatment at this point because of this variation that exists among clones. And we should continue individualizing treatment for each patient. To do that, we have several targets, and there are not genomic targets, but there are metabolically active targets. So we have several parts or metabolic paths that can be identified to treat the patients. And since each clone offers different heterogeneity, it's best to combine them, trying to capitalize on synergy among agents and also increasing or decreasing the toxicity. One example of that was actually initiated and pioneered by Dr. Bob Orlowski and his group in the MD Anderson, in which Dr. Jatin Shah presented for the first time carfilzomib, pomalidomide, and dexamethasone, 3 agents, 3 different modes of action, and synergy among them. This is a more optimized combination, the one I'm going to present, just to remind you that pomalidomide and low-dose dexamethasone in the relapse refractory setting will give you usually a PR of 30%, an overall response rate of 30%. Doesn't matter whether you have high-risk genetics, the pomalidomide low-dose dex background will give you that type of response. When you combine the carfilzomib, pomalidomide, and dexamethasone in this regimen, we expect to increase it at least substantially among that 30%. So this is actually a trial by the Europeans, in which they modified the trial originally by the MD Anderson, in which instead of giving the carfilzomib in the typical double dose weekly for 3 weeks in a row, this time they're using weekly carfilzomib, and they're using a phase 1, phase 2 fashion to try to increase the dose between 27, 36, 45, and 56 per meter square. So there was an MTD phase 1, and then a phase 2 with the endpoints of overall response rate, and of course duration of response, PFS, time to progression, etc. What was also very important on this examination is that they did a very strict control of risk factors before initiating therapy, and they monitored the blood pressure. They gave proper frontline management of these issues to avoid the cardiotoxicity that may occur in 5% or 6% of the patients. These are the patient's characteristics, and as you can see, there were about 20% of the patients with unfavorable cytogenetics, with deletion 17 in about 15% of the patients. Many of the patients were transplanted. 100% of the patients had received a prior lenalidomide, and they were primary refractory to both agents in about 50% of the patients. Long story short, CR rate 6%, VGPR 26%, for an overall response rate 64%. So remind you, the pomalidomide X baseline is 30%. So this regimen allowed to increase it to 64%. And what is more important, the PFS extended to 9.2 months. With this new regimen, with the new paradigm, the toxicity was decreased significantly, and as you can see here, the major events, grade 3, 4 events, were also decreased compared to when there was not instituted these procedures. So in conclusion, the combination of carfilzomib, pomalidomide, and dexamethasone doubled the response rates expected and increased the PFS expected for that group of patients. If you're more interested in cost containment, you can follow our experience, which is the clarithromycin, pomalidomide, and dexamethasone, in which it's an all-oral regimen for patients who are highly refractory. In this type of schema, clarithromycin 500 milligrams PO/BID with a typical POM and DEX in a weekly fashion. The criteria of inclusion are there. Just suffice to say that the number of prior therapies in this group of patients were 5, and we had a large group of patients with international stage 2 or 3, and a large group of patients with high-risk cytogenetics ranging from 60%. 90% of the patients were double refractory, and these are the response rates. Overall response rate of 70% overall, and in the double refractory, 56%. That compares favorably to any combination with pomalidomide and carfilzomib or more expensive. And the PFS reaches almost nine months in this group. And it's irrelevant whether the patients are double refractory or not. They have the similar results. And it didn't matter also the cytogenetic group. The median survival in this group, remind you, the double refractory overall survival is only 9 months. Here we found 19 months. Dr. Susan Lench already mentioned this study, and it's worth mentioning because it was just recently presented in the ASH by Dr. Ashraf Badros. In this, it's a combination of pembrolizumab, pomalidomide, and dexamethasone in the similar population of patients. Perhaps there were more patients with prior 2 lines of therapy, so lesser pretreated patients. But more than 70% of the patients were priorly transplanted. Many of the patients have received Vortex, carfilzomib, and lenalidomide. So you can actually talk to them or identify them as double or triple refractory. Long story short, the overall response rate, 60%, so it also doubles the 30% expected from POM-DEX, and the progression-free survival also increased to 17.4 months. Very well-tolerated regimen with some toxicities that require more attention in larger studies. So in the era of novel therapies, I hope I had convinced you that the consideration of relapse patients has to be always that those patients are higher risk, that the genomic instability at this level precludes the use of molecular targeting. I'm very interested to try to establish better regimens for these patients, but given the high level of heterogeneity, combination between classes are important, and the incorporation of monoclonal antibodies would be very important in this case. And I hope I also convince you that I never will advocate for one size fits all. Thank you very much. These are all my collaborators.